Your client may also have reversible dementias, also referred to as pseudodementias or delirium. Here's a list: intoxication, affective disorders, infections, nutritional, metabolic, or vascular disorders, head injuries, brain tumors. The acronym on the right, dementia, gives you several types of dementia that your client may have that are reversible. After treatment or time, they may go away. D, drugs. How many medications is your client on? With more than 20 medications, they may be apt to have a reversible dementia or lifetime substance abuse. E, emotional. Depression looks an awful lot like dementia. In fact, it's nicknamed transitional dementia. Metabolic disorders. Eyes and ears, sensory impairments of. N, normal pressure hydrocephalus. T, tumors, lesions. I, infections such as urinary tract or upper respiratory. Anemia, which could be a B12 deficiency. Anoxia. Hormones. Stress, sleep deprivation. Any number of symptoms could present like a dementia. If your client has the following comorbidities: a physical disability, depression, diabetes, pain, the client may present with greater cognitive deficits on top of their irreversible dementia. It's our job to decrease confusion. Check the client's medications for side effects. Make sure they're properly hydrated with water. If they're on Lasix, make sure they're still drinking water, because many clients on Lasix avoid the water so that they don't have to go to the bathroom as frequently. Offer extra assistance when the client is transitioning between states of dementia to the next stage, or when they're having a transition in their life, like a spouse passes away, or they move from one environment to another. Remember that repetition is a substitute for memory. Get your client into a new routine as soon as possible, or get them back to their old routine as soon as possible. When your client demonstrates a cognitive change or a change in performance, refer to therapy as soon as possible and report those changes. There may be a chance to get the client back to prior level of function if we can make the new environment more familiar, or get the client back to their old environment as soon as possible. Make cognitive screens part of your quarterly screens. The brief cognitive rating scale would be an ideal assessment for this, in which it takes 10 to maybe 15 minutes. If you go on my website under resources, there are several cognitive assessments available for review. The brief cognitive rating scale would be the assessment that you administer to get global deterioration scale scores, which we had reviewed earlier. Compensate and communicate. When you find a way of treatment or approach that works for your client, communicate with the rest of the team so that you can get continuity of care. Every time you work with a patient, they're like a puzzle, and when you find out the solution to the puzzle, you want to share the solution with other caregivers, because this will streamline day-to-day care rather than having to rediscover the solution to daily struggles. For example, there are many times that a speech pathologist may use a memory book with a client to help them remember day-to-day routines or where they are, or more like a reality orientation book. It's not going to be very helpful unless everybody on the team is using it. I know our speech pathologist has a whiteboard on the unit in the hospital, our rehab unit, and it says today is the name of the day, and then she writes the date. Now, she doesn't work on the weekends, so I update the date on the weekends. If I didn't do it, then the reality orientation purpose of that dry erase board would be moot. Let's talk about what people can do at the different stages of dementia so that you can come up with reasonable expectations for goals. We'll talk about early, mid, late, and terminal stages of dementia. In early stage dementia, Reisberg had described this stage as similar to an 18 to 20-year-old. It is reasonable to expect this client to ultimately live home alone. Please get them home within a month while they still have the residual abilities of their routine. Once the client's away from home longer than a month, anecdotally I've observed that the client's cognition starts to unravel and go to the next stage. It's reasonable to expect this client to ultimately become independent in self-care, like emptying their colostomy bag or taking pre-sorted medication from a pill sorter. It is reasonable for this client to go back to work, although we should decrease their job expectations due to a loss of higher executive management skills used to perform their job, like organization skills. For example, yes, maybe they're going back to the laundromat, you don't have to worry about anything, but when we talk about month end, doing fiscal management, that may be an issue. Hey, Dr. Roberts, maybe you shouldn't be the lead surgeon on your medical team. Perhaps you can step down and become a consultant, because if your cognition changes over the course of your career, we wouldn't want you to make a mistake and then find out that you shouldn't have been practicing medicine. Clients at this stage can make plans before actions. This is the divergence, so making a grocery list for what they're going to cook during the week. They can also be novel, creative, and spontaneous, wonderful skills as a driver and for cooking. Mid-stage will match a psychological profile of perhaps a 12 to 13-year-old. Now, just because I say that they may process information like a 12 to 13-year-old does not mean that you should talk to them like a 12 to 13-year-old. This is a grown-up. I'm just giving you the ages to understand more fully how the client might process information. Remember that routine is a substitute for memory, especially in mid-stage. Get them in the familiar routine as soon as possible. Try to get the client home to their familiar routine within at least 2 weeks. The residual ability of their routine is very brittle and will unravel in about 2 weeks, according to my experience. They might need setup for tasks and distant supervision to perform as the ultimate goal. At first, have the client copy the activity after demo and give you a return demonstration of that technique. Work on the same skill every day until you observe mastery. This may take about 2 weeks. If you do not see mastery or even a improvement in 2 weeks, then what you're asking them to do may be too difficult. Family notices the most changes in the client in this stage because this is the stage of dementia where we see the most observable ADL decline. This is the best time to talk to family caregivers about altering our approaches, altering the environments, because the family understands that there may be dementia. If not, family really does put the fun in dysfunction, and denial can last very far. In fact, healthcare workers are often the last ones to admit that their loved ones have dementia. Because of our knowledge base, we have many excuses medically why the client might be struggling. I'm not saying that's a good or a bad thing. In fact, thinking more clinically reduces feelings of stress and encumbrance, and the client will have greater care. So maybe healthcare clinicians aren't labeling their loved ones as having dementia, but they certainly are providing good quality care and attention. Late stage dementia, the client will need up to total assistance in all care. Someone needs to be involved in all of life's activities, like a 3 to 5-year-old. Again, please do not speak to your client like they are a 3 to 5-year-old. Only give them responsibilities that you might trust a 3 to 5-year-old to do. They are dependent upon another person for survival, and there is very little new learning, so it's time to get rid of reality orientation. Then we're getting back over to reminiscence therapy. The client can become agitated after an outing or a significant change in their routine during the day. If they become agitated or demonstrate behaviors at the same time every day, we call this sundowning behavior. Sundowning can occur after a change of environment, routine, or caregiver. At the end of late stage, the client can no longer walk. That's when we know that they are exiting this level, this milestone. Once they lose the ability to walk, things really snowball. We'll talk about that in a moment. One great non-pharmacological intervention for behaviors is activities. According to Algase's need-driven behavior model, behavior is an expression of an unmet need. Mostly behaviors may be a null behavior as a substitute for not having an activity to do. At this stage, clients can participate in repetitive, low-level activities. This is called sustained action activities in Claudia Allen's information processing model. Sustained action activities include rocking in a rocking chair, twiddling, stirring, fiddling with an activity apron, sorting, sorting things into 2 groups, sorting things into 3 groups. Sanding a block of wood, something that's redundant and non-sequential, meaning that it doesn't have to end, it has no beginning, middle, or end, it's just like puttering. Snapping green beans, husking corn, brushing a dog. Terminal stage will match the psychological profile of a 0 to 1-year-old. We refer to many of these clients as bed-bound because they will stay wherever you put them for the rest of the day for the most part. We see varying alertness levels throughout the day. In fact, it could take up to 10 minutes to increase their arousal state through sensory stimulation, which I will give you some techniques in a later video. We see a severe risk of sensory deprivation because of the difficulty processing sensory information at the midbrain and cortical levels. We also see rigid muscle tone that can result in a fetal contracture if they are not having daily range. Skin integrity becomes compromised as the client is no longer eating. They remain very stationary. Hydration becomes compromised if they're not having IV therapies, whereas you end up getting paper-thin skin and a high risk for pressure ulcers. Once the client forgets how to feed themselves, they have about a 6-month life expectancy, and that is a hospice marker. When the client no longer can feed themselves, they are a candidate for hospice. I'd say get them into hospice because then you can afford the nice wheelchair. And then they die. The most common cause of death is aspiration pneumonia, and I really don't like the American rehabilitation model because many of us don't even have a touch on palliative care. Hospice is often its own agency, and if you work in a skilled nursing facility, well, people with dementia spend maybe their last 2 to 3 years of their life with some sort of one-on-one care. Yet in the nursing home, you work with a client until maybe their last 6 months of life, and then they get sent over to a hospice program. So this is a very irresponsible practice because we'll be looking at, from a rehab standpoint, get people better, get people better, get people better. Oh, we can't get them better. Oh, they died. And it feels like such a failure. And I feel like sometimes I should fill out my resume as everyone I have ever taken care of as an occupational therapist has died. Would you like to hire me? Spotless record. There's nothing wrong with your client passing away. You're born, you die, and living is what happens in between. And we are in the end of life business when we're looking at long-term care and assisted living. We're working with the geriatric population. You die. It's our job to make that transition as comfortable as possible. In some rehabilitation is necessary because people do end up getting in a very febrile state, but it's important to also understand that this is a natural progression of life and to give more palliative care. You know, there's a 105-year-old woman. I shouldn't be forcing her to get out of bed if she's telling me this is my time. I've lived a good life. I can't say, hey, you haven't met your rug category yet. It's really not a good way to think. And I personally feel like there's just something wrong with the American healthcare system in that clinicians are being pushed to push the clients to exercise until they're ready for hospice. And it's unnatural. It's unnatural, and I think that Medicare should have a responsibility to advocate for the clients to have more palliative care, pay for maintenance and hospice type of services, create a palliative service for the last year of life instead of the last 6 months of life, where people can get the one-to-one care, the activities, the animal therapies, while working with caregivers to prevent them from breaking their backs, from moving someone who's catatonic, comatose, not alert, variable performance, and then put them on hospice. And then we won't have to talk about this whole rehab thing. It's not a failure when your client passes away. You're born and you die. And at the end, we have a moment. And I think that it's very important to grieve. I've started some grieving programs at facilities that I've worked at. I wasn't really sure how to start it. It was recommended to me as a young clinician when I worked at the GREC program, and I took psych classes. We talk about Kubler-Ross and stages of grieving for the patient, for the patient's family, but we never really talked about it as the clinician. You work at a company for a couple of years, you see clients go downhill for about 3 years, and then they're gone. They're gone to hospice, and you feel like you failed. It's hard to refill that cup and go on if you don't get to grieve. You send people onto hospice, you don't get to grieve. So I've started grieving programs, and some of these ideas I had, they were recommendations from the Cleveland Alzheimer's Association through their Train the Trainer. A guest book, that's what they did at the GREC program. We signed people out, and there were books and books of names. It made their life tangible. Look at all these people that we took care of. Look at all of these people that we helped transition to the end of their life. Flowers. When I worked at Pleasant Valley Rehab, we'd buy carnation to put at the front reception desk with a little card on it that said their name. Also did that at Northeast Rehab in Bedford, New Hampshire. Vigils. The hospital that I work at has a chaplain service where chaplains can come up to the client's room, or their family can go down to the chapel for a service. Have a basket with note paper where you write little sentiments about the client and put it in the basket as a remembrance. Sometimes when clients aren't saying very much, the few things that they do say resonate with you, and it could be helpful to write down the things that they say. Like one client told me, "Thank you for being so patient with me. I know sometimes that can be difficult." Another patient said, "I hope you get all the same things that I do someday, and someone makes you get out of bed when you don't want to." Well, I think she was a little frustrated and trying to teach me through the golden rule that it's not a good situation to be in when you're in the process of dying and someone's trying to encourage you to get out of bed. I was telling her, I don't want you to get DVTs, I don't want you to get pressure ulcers, it's important to get up, get out of bed, drag a comb across your head. And, with her dementia and her limited expressive language, that was her way to tell me that she was dissatisfied with my efforts that day. And, I feel bad. I learned from that day. Just say goodbye. It's important to say goodbye however you can. Oftentimes I'll find out that my patient passes away, and I'll stop by their patient room. I'll stand at the door and I'll say, "Hey, it was nice knowing you. It was really nice knowing you." Something. This will help you refill the cup so that you can give to others. And thank you for doing what you do. Man, if your patients have not touched your heart, I think that you're in the wrong business. If you want to just go have a job, go work at Fidelity. That's all I'm saying. I promise, that's all I'm saying. Okay, now we're going to get into management of dementia.